introduce myself. I know a lot of the people in this room, but for those of you who I don't know, my name is Jerome Smith. I practice dentistry in Lafayette, Louisiana. I've been in private practice for 34 years. I just saw the other day, I got a notice that we're having our 35-year dental school class reunion. It's just hard to imagine that those years have gone by so fast. So some of my classmates are here, Gerard Karam, Jim Iverstein, Bill Donnelly's going to be here, Hunter Charvet, and some other friends in the audience as well. But I'd like to thank you for having me here today. I knew that today was going to be a problem. I got my car, a new car, and it says engine control fault. I don't even know what that means. So, you know, big red thing, so I just kept driving. And honestly, I don't even know where Harahan, I don't even know where I am. I lived in New Orleans for 4 years. But anyway, nice looking crowd, definitely a nice facility. And is Darryl Borg here yet? Where's, God, I thought Darryl would be the first one here. But I really want to thank Darryl and New Orleans Dental Association, particularly Joel with Megagen USA for having me here today. We're going to talk about some things that are observations from my practice. I want you to know I don't lecture for a living, and it's become real obvious throughout this course. In fact, when you look at your evaluation forms where it says, let me put my glasses on, where it says, was the speaker organized right now, you can go ahead and check off no. Was the subject matter well described on the pamphlet? You can put check no also. And would you have him come back and check off hell no for that one? Because I'm a clinical dentist, I have all the headaches and all the nightmares and then some that all of you have. And so I appreciate where all of you are coming from. We're going to talk a lot today about a lot of different things with some emphasis on this particular implant system. I will tell you this, Joel did not call me to buy the system, I called him to buy it because I was just so intrigued by it, and I'd worked with the rescue system for Megagen before, and this probably has revolutionized, for me, implant practice more than anything. You know, we've been placing implants for 28 years now. First case I did was in 1986 on my dental receptionist's husband, and we did 2 core vents. I did one on the right, and my partner, Dr. Barrios, did one on the left. Mine failed, his worked. And back then, I'm sure we were generating a lot of heat. We didn't have water pumps with coal saline and all these things we have now. So, you know, it's been neat to see how much things have evolved. At the same time, it's been interesting to see how much stuff we've acquired in terms of tools and bone grafting and this and that and this and that and all the instrumentation that we need to run a practice that's focused on implant dentistry. So there's a lot going on in the implant industry. A lot of it's driven by money. You know, as a clinical dentist, I'd like to kind of try and decipher through some of that stuff and just kind of talk about, you know, what's really working well for us. This is the thing that I'm into. You know, if we can take somebody like this where this tooth is going south, but this tooth back here is still good, and we do, I swear to you, we must do this almost every day. It's just so common where somebody's got a 3-unit bridge, and or 4-unit bridge in this case, and one of the abutments is history. You know, and if it's an endo tooth, the chances of it becoming a problem later on are great, and that's what's exactly happened here. And so a lot of times we will do a crestal approach, sinus lift, put in a large diameter AnyRidge implant, and I mean you can be going into 3 millimeters of bone with this particular implant, and when you're putting it in, it's like, man, I can't believe how much torque it's taken to put that thing in there. And so, you know, osseointegration is important, and that's where we're all headed, but initial fixation is a big deal. And so if we have an implant that will give us good initial fixation in the maxilla, then this will allow us to be able to not have to graft this and then come back 6 months later, put the implant in. We'll put the implant in now, you know, section the bridge, take the eye tooth out, take this canine out, do an immediate placement with this implant. When this thing goes in, these flutes really engage the cortical as well as the cancellous bone very well. And so sometimes you're using 50, 60 Newton centimeters of torque to get these in. And we'll talk about immediate provisionalization because this patient's going to leave with a canine. And I'm not going to make an Essex appliance, and I'm not going to make a flipper because I wouldn't want to wear one for an afternoon. I'm not saying I never do, but it's not very often that we do because we get such good fixation with this that we can put provisionals on immediately and then shape the provisional to create emergence in the soft tissue to where when the final restoration goes in one of these days, it looks like a real tooth. So as an overview, we use Blue Sky Bio, internal Zimmer hexed clone in the office, not very much anymore, but it was kind of my go-to implant for a while. My partner uses BioHorizons because he thinks that the laser lock is the key to implant dentistry. I think it's the most important thing out there because you've got these laser grooves and the connective tissue apparently attaches to these grooves, and as Dennis Tarnow said, let's wait 10 years and see if that really was a good idea or not. So what I like about these is they do make a 3.0 millimeter diameter implant for those tight spaces, maxillary lateral incisors, and then you can have a custom zirconium abutment so that you can make two all ceramic crowns that look like real teeth in the front, and that's quite an evolution from what we were doing even 10 years ago. Megagen also has a 3.0 millimeter implant, which came out how long ago? It's recent. Okay. We have some, but I haven't done any yet. And I'm going to talk a lot about the AnyRidge system. I think that probably 85 to 90% of the implants that I do now are this system. I'm going to mention is Spree Dental Lab in Golden, Colorado, and Midwest Dental Ceramics, which is in Iowa. These are two labs that we use to make custom abutments, and I'm telling you, when we got out of doing stock abutments and went to custom abutments, there's no way to go back. There's no way to go back. And I'll show you some examples. I've seen in the literature that it says one of the #1 causes of implant failures is cement getting shoved under the gum line. And I've seen it, and I know Ed Savoy's seen it. And we are using the custom abutments because we can tell the lab we want a 0.5 millimeter subgingival margin on the facial of 8, and I want 0 on the mesial and distal, and I want a 1 millimeter margin on the lingual for a central. In the back, everything is either 1 millimeter supergingival or it's right at the free gingival margin. So then it's just about impossible to trap cement down there. But the other day I had a real nice case I did. Chuck Bernard, one of my best friends, restored tooth number 19. The x-ray looked perfect. But man, he kept having some oozing and some pus. And I opened it up. Before I opened it up, though, I accessed the coping screw through the crown because I wanted to get the crown off. It's so much easier to do periodontal regeneration around an implant without the crown and the abutment in the way. So I unscrewed it. As soon as I unscrewed it, there's a huge piece of cement right on the mesial of this stock abutment with a crown attached to it. And I wrote in my dictation to him, I said, this is why we're not using stock abutments anymore. Because the mesial margin of this stock abutment, because it's 360 degrees, the margins are not following the free gingival margin. It's just a circle. And so the mesial margin was subgingival. And if you take a crown and you load it up with cement, you get hydraulic force, and that cement will take off. I've seen some pictures of it on implant threads. I mean, it can really cause a mess there. So, what we wound up doing is opening this area up, taking out the supernumerary tooth, apicoectomy, bone graft, temporize. Bonded temporary. And then after 6 months, this implant right here, and in an area with a huge graft, this thing engages peripheral bones so well that we put this in, it's just as tight as a drum. And I wouldn't feel comfortable putting in a conventional machine threaded type root form implant in a graft like that. These are some AnyRidge implants that were placed number 12, 30, and 19 sites. That was her case. And like I said, these things just grab that bone to the point that you feel like you could almost make your impression that day and make your final crowns then, which we don't do. The concept is that we screw in an impression transfer, we take an impression, then we unscrew this and we send it off to the lab, and they'll produce, in this case, a zirconium abutment with a titanium base, and then this thing goes into place, and it's anatomically, it's perfect. And I'll also, as I said before, then I'll have the lab make a custom abutment, a nice lab process provisional restoration to go on that same day. And it's just like this. Instead of taking out a stock abutment, grinding on it, part of the margin supergingival, a bunch of it subgingival, and it just doesn't work as well. It's kind of the same thing on the bottom. So here's an example of a case. This guy used to live next door to me. He had to lose both of these teeth. Immediate placement of AnyRidge implants. Real good initial fixation. I'm going to tell you this. We've been using tapered screw vent for a long, long time, and my immediate placement success is not what it is now because of the change. I just wouldn't get that good of initial fixation all of the time Whereas with this, you get it all the time. And I'm not saying we never have failures, but they're really pretty rare. They really are. And so these are the custom abutments back from Midwest Dental Ceramics. These things are actually dentin colored. They're not white like those. It's a shaded zirconium, I guess. And these are the temporaries that they made for the case. So now I'm done. This guy goes back to Sam Moss, and Sam's going to make his final crowns. But look how easy it's going to be for him to restore this. So here we are placing an AnyRidge implant in that first bicuspid site. And I'm going to go ahead and put an extension on so we can look at the lineup. And then we're going to start creating the osteotomy for the second bind, because this is a tight spot, a really tight spot. So now here's our pilot drill. Enlarging that osteotomy a little bit. And then we'll go ahead and place our second implant here. So we're still doing the osteotomy. And putting the second implant in. And so now we have both implants in place. Here we are here. So this is a tight spot, real tight spot. But these do nicely. The nice thing about platform switching is you can get a little closer to one another than you can with non-platform switched implants. I just like these things quite a bit. We already saw that slide. You look at this thread into this bone, and just try and imagine, you know, how rigid that is compared to something that resembles a machine screw. It's just like a night and day difference. Same thing here. And so the fixation is really remarkable. Here we're using the Prexion. We're looking at the amount of height and width available. There's our AnyRidge implant in that site. And this bone, a lot of times, is like I said, it's just like balsa wood. And to put a tapered screw vent in there, when it was time to take the healing screw out or put the abutment in, I was always scared. I was always thinking, you feel that? You feel that? With these things, I don't ever say, are you feeling that any? Because you know that thing isn't moving. And that's a quantum leap from where I've been over the last 20-something years. You know, y'all have put me on the payroll. Before we went to the AnyRidge implant, we were using the Rescue implant, and that's how I met Joel. I was in San Diego to American Academy of Implant Dentistry meeting, and I saw this thing, and I said, man, this looks neat. So we take a molar out, put this guy in. They work well. AnyRidge is better. They're just better. Okay, but for the time being, you know, it was a good. Who is this? Who's that?
I don't know. It was in Korea.
Okay. So here's an example of using this Rescue implant. Like I said, nowadays I would use the AnyRidge instead because of the thread design and so forth. But this has worked out well, you know. And so here we took out these two molars. These were placed immediately. This is the case after it was not restored yet. So she had some other stuff. We use every brand. Tapered screw vent, Straumann, tapered screw vent, Straumann, Rescue. You know, this is a patient's in progress. You know, she's had some work done years ago when she has another issue. She comes back from Patterson, Louisiana. But I like these things, and I really like them a lot. And Joel, after lunch, we're going to start off with you talking about the features of the system. I'll show you a little bit about it, what I know. But he's much more knowledgeable about the technical stuff. This, to me, looks like a sheetrock screw. And when you put it in the bone, it takes an incredible amount of torque to seat these things. And if you put like this implant right here, 7 millimeter, and you try to put it in the mandible, you're not going to get it all the way in. I mean, it's just not going to happen because the bone is so dense. So you're going to want to use a narrower diameter in these molar areas unless it's an immediate placement. But, you know, nowadays there's so much hype out there about what's going to be the perfect implant. We're looking at platform switch. We're looking at stock abutment designs. We're looking at this deal right here, whatever that is. Here we're looking at the pitch of the sharpness of the threads, which I think is a big deal. And so, you know, in the last couple of weeks, I've removed several first and second bicuspids, and all I did was take a 3.8 millimeter diameter drill and just refine the apical part of the socket, and then screwed it a 4.5 by 11.5, just done, finished. You know, and when you're putting that thing in, you're thinking, man, this is solid. I mean, this is serious. Instead of, now I've got a machine screw that really isn't tapered, and now I'm packing bone around it and doing all these things. I'm going to put a temporary on right away on this other deal, you know, because the initial fixation is just that great. So You've got this double offset for a better peri-implant biotype in this area here. Real narrow core. So we're not drilling a 7mm hole. We're only drilling a 4/8. And the 7mm implant is going to go in to type D3 or D4 bone. It's D1 bone. Then we're going to probably put in a 5, maybe, you know. So there's a little bit of thought that goes into the process of placing these, but it's kind of one of those things that once you kind of get the knack of it, it kind of just starts to make a lot of sense. And as I said before, these are knife thread like flutes on these things, so particularly maxillary bone, it really works out well. These are some of the cases that were done in 2011 when we first started using. How long has the system been out?
Worldwide, about 4 years now.
Okay, so these were done in 2011. Taking a molar out, dilate the furcation bone, this thing goes in solid, 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 really nice. Here's a case that was done on a physician who's a friend of mine. This is all he had left. So we took the SLA drill from Zimmer, made a window, put all our graft in there, let it heal about 5 or 6 months. Then when it's time to place the implant, I noticed that it had a really deep pocket on the mesial, this third molar. So we took that tooth, took the tooth out, grafted the site, screwed this in, and I'm telling you, this is just as solid as it looks. I mean, the day you do it, you think, man, we ought to just take the impression now. But instead, I'll wait 2 months, make an impression, make a custom abutment, and then just go ahead and restore it. Same thing here. Took this tooth out, dilated the furcation bone. Sometimes we'll do that using a bone spreader, or in fact, a lot of times I'll use one of those motorized bone spreaders to where you're going in at 50 RPMs and it's just drilling, it's creating an osteotomy, then you back it out and go to the next diameter and then screw this guy right back into place. So like I said, you know, here 3.3mm diameter core, 4.8mm diameter core. This is going to go into D1 bone, and these are going to go into D3 and 4 bone. Same thing down here. This goes into dense bone. This goes into bone that's not so dense. So it's pretty slick. And the thing that I took this picture at the office because I put all my cup holders in on the wall with machine screws, and they're all falling out of the wall. You put a screw in like this, it's not going to come out. So we talk about osseointegration. It's amazing. If you have an implant with 50% bone loss, a tapered screw bed, you can get in there, put your thing in, get your socket wrench, you can back it right out. I don't care how long it's been in. You know, and I've done it a bunch of times. If you put one of these in and you got to take it out, you got a problem. You're not going to get it out. I mean, you're not going to get it out. After 3 months, it ain't coming out. And so the only way to get it out is you're going to have to get in there with a burr, a liniment burr or something like that, and get rid of these guys so that you can back this thing out. We had a guy named George Seifer who's he's another story. Anyway, 8.5mm implant. He lost about 3mm of bone initially because he was, I don't remember what the problem was. Just didn't heal well, and I said, look, we got to take this thing out and put another one in. Couldn't get it out. So the maxilla, 8.5, we got 3mm of bone missing. So we only in there 5mm. It'd been in 3 or 4 months. I could not get it out. And so wound up cleaning the threads out, grafting and closing it back up. But I guarantee you, if it was anybody else's implant, I probably could have got it out of there. So that's, you know, as far as getting initial fixation in cancellous bone, this really it does the trick. There's another implant they have called NE1. I'm not using it, so I can't really comment on it too much.
That's mainly for dense bone.
It's for dense bone.
Yeah.
Okay. Here's an example of those type implants. And so now we can start planning our implants. And we're going to use AnyRidge implants in this grafted bone. I just think this is a better way to go in terms of getting better primary stability and ultimately a better long-term result. So here we're treatment planning this upper right side. Here's where we are here. And now we're going to start looking at the upper left side. Got a good width and good height now. Same thing here. Same thing here. And so here's what the case looks like. These implants were buried because they're in grafted bone. I just want to make sure that he wasn't getting any pressure on them. We get the single implant on the lower right side. So this is what we'll show to patients when we're trying to get them to ascertain what's going on. Here's a full dentition. This is all you got left. All right? And out of all you got left, everything in yellow is a bad thing. It's all infection. And they kind of start to get it, you know. It's like, well, we can bone graft here, 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 root canal, and use these teeth to support the provisionals while everything's healing, okay? And so we have fixed cemented bridge work on the top. And then after this is healed a little bit, then we'll come back and put implants in these areas as well as down here. This is what it's going to look like when it's restored. And that's what we did. So here's our AnyRidge implants on the bottom, tapered screw vent, AnyRidge, tapered screw vent, AnyRidge. Today, I do all AnyRidge. And so here's an after shot of everything in place. All of this is healed. It's been in provisionals a long time. Then we come back and put our implants in and our provisionals. This is after. I'm sorry I don't have a shot of the lip raised up. That's before. That's after. Before and after. This is a guy named Scott from Jennings, Louisiana. When we're doing a case presentation, I'll image a patient like this in Photoshop just to show him what I think we can accomplish. This is what he started off with, just real bad dental phobia. That's a poor imaging job. But real bad dental phobia. And he's overclosed posterior. I mean, this is a mess. And a lot of people look at this and just start thinking, that's dentures. You know, this guy's like 32 years old. He's got a good job. He doesn't want to have false teeth, and neither would I. But this is a wreck. So what we did was, in his presentation, identified all the problems, and he's got them all over the place. And so what we're thinking about is just trying to get him back into first molar occlusion. This is his scan. So here's what you got. Here's really all that's left, and TENS history also. And so what we think about is putting implants in these sites, fixed bridge work in the front. That's option A. Here's how it would be restored. One here, two down there, and then all the way across the top. And then you have option B. And option B is going to be to, take everything out on the top, put 4 implants in, and make some palatless overdenture thing. And he really wanted to keep his teeth. So this is what we wound up with. These are all AnyRidge implants. Just really super result. Looks good in the mouth. Looks good on the x-rays and all that. And this is the day we put the case in. So everything's kind of bloody. This is after he's healed for a week or so. Right side, left side, he's bleaching right now. That's before. This is after. And I just think it's cool that we can even do this nowadays. I mean, I wouldn't have dreamed in 1980 we got out of school that we'd ever be able to do anything like this that would look this good and be able to give patients back their original function again. So real good patient, good guy. I'm glad it all worked out for him. That's all I got. And if you have any questions for after, I'm going to hang around a little while I'm waiting for the guy from the Porsche dealership to call me back. Can he ever call me back? Tell me what that engine is going to blow up thing. Thanks very much. I enjoyed it. Thank you.
Sholnick Advertising, making phones ring since 1982. SholnickAdvertising.com.